Hello and welcome to the Inpatient Diabetes Management Nursing webinar. My name is Philomena D'Souza. I'm an advanced practice nurse in endocrinology. I'm here today representing the Champlain Region Hospitals Diabetes Network. I am the co-chair of that network, and my goal today is to increase your knowledge as a bedside nurse of best practices in diabetes management. What I'm going to tell you today is based on the Canadian Diabetes Association Best Practice Guidelines from 2013. These are the most recent guidelines that we have, and an expert panel is now looking at reviewing those guidelines, and a new set will come out in 2018. You can choose to view these videos one after the other, depending on how much time you have, or you can watch them separately, and you can view them as often as you'd like. And thank you for participating. It's important to know why we're talking about this, and across the region, about 25% of all hospital beds are filled with someone who has diabetes. And it's important to remember that patients who have diabetes are more likely to have long length of stay and to be readmitted than someone who doesn't have diabetes. Unfortunately, hyperglycemia is common in hospitals. And the reason for this is likely because when people are admitted to hospital, they're not admitted to hospital necessarily for their diabetes, but for other medical or surgical reasons. And the diabetes is not seen as a priority, and it's often overlooked. At the hospital network, we are looking at collecting data to see whether how big this problem is in our region, and whether implementing certain standardized protocols can make a difference in improving the problem of hyperglycemia in hospital. Things that contribute to these highs and lows and fluctuations in blood sugar are changes in diet. When patients are admitted to hospital, they are not able to eat in the normal way. They may have to fast for tests or procedures. They may not like the food that we serve them. There's often changes in their medical condition or medications that we may give them, or their diabetes medications may be changed. Clinicians often manage the diabetes one sugar at a time rather than looking at the patterns and making adjustments to their blood sugar management based on the patterns that they see. There's often lack of coordination in the timing of the administration of insulin, the checking of the blood sugar, and the meal times. There's often lack of communication, in particular at transfers from one unit to another or at discharge. And there's frequently errors in writing and transcribing orders. And there's prolonged use of sliding scale insulin, which is not the most effective and safest way to manage diabetes. It's important to know that hyperglycemia has been associated with poor outcomes. There's been more and more research in the last 10 to 15 years looking at this problem. And depending on the clinical situation, the researchers have found poor outcomes related to hyperglycemia, including higher mortality rates, longer ICU stays, longer hospital stays in general, more complications, as well as an increase in the risk of post-op infection. So this is a problem that we have to address. It's important to know that based on this new research, the Canadian Diabetes Association recommends that we target blood sugars of 5 to 10 in the general admitted population, so in the non-critically ill patient. In the critically ill patient, the recommendation is to aim for sugars of 8 to 10 because there has been some research showing that hypoglycemia is also linked to poor outcomes in those patients. One of the things that contributes to hyperglycemia and that complicates the picture is important to realize that there is this vicious cycle that occurs when patients have an acute illness. When a patient is acutely ill, they have an increased stress. The stress hormones go up. We frequently use glucocorticosteroids, which are drugs that cause hyperglycemia. And then we often have patients who are now bedridden, unable to do their usual activities. And when you put all these things together, all these things contribute to hyperglycemia. Hyperglycemia reduces the immune response and decreases the ability of the person to heal. We have an increased oxidative stress, which then impacts the acute illness. And then we're stuck in this vicious cycle, which likely contributes to the poor outcomes that we see. So just in summary, we see that hyperglycemia really causes many problems and impacts outcomes for patients. And by not addressing this, healthcare providers are contributing to poor outcomes, increased length of stays, and increased healthcare costs. And we need to do something about this. The Canadian Diabetes Association, therefore, has put out a checklist for how we should manage diabetes in the hospital setting. And what they say is that if the patient is able to eat normally and there's no contraindications, if it's appropriate, they should continue their usual medication when they're admitted to hospital. And if we can't, because of their medical condition, there's contraindications, or they're unable to eat normally, then we should use insulin as the first choice for treating their diabetes. We should not use sliding scales only, and we should use instead basal bolus correction insulin, which is the gold standard for treating diabetes now, and I will explain that to you in the next few slides. And we should also be careful to avoid hypoglycemia for patient safety. Other things that are important to remember when we're talking about managing insulin in the hospital setting is that patients who have type 1 diabetes are insulin deficient, and these patients need a long-acting or basal insulin at all times. This should never be stopped or held. It's important to remember that these patients need insulin. In their case, it's life-sustaining. And we do have to recall that before insulin was available for treatment, these patients died from the lack of insulin. So insulin is life-sustaining. For patients who have type 2 diabetes, they still need basal insulin, and it should really rarely be held. If these patients require insulin for the treatment of diabetes, then they're not producing enough insulin to maintain a normal blood sugar levels. So in effect, there's potential harm in just using sliding scale insulin as a modes of therapy. It's a very reactive approach to treating diabetes where we're waiting for hyperglycemia to occur before we do anything about it. And this is really what causes many fluctuations in the blood sugar and really not very good for the patient. To understand how basal bolus insulin works, we have to go back to the basics and think about how a healthy pancreas works. And what we have to remember is that we need insulin 24 hours a day. And the reason we need insulin is because our cells need energy. We have to think about the role of insulin in the body. And the role of insulin is to bring sugar from the bloodstream into the cell so that the cell can use the energy. Now that energy comes from, when we're not eating, comes from the liver where we have stored glucose, and through gluconeogenesis, we access that glucose. But we need insulin 24 hours a day, what we call a basal insulin, to maintain that normal cell function. And then when we eat, the pancreas will magically make just the right amount of insulin to deal with the bolus of food that contains carbohydrates. So we produce a bolus of insulin every time we eat to handle that extra sugar, and then we go back to our basal amount. And this happens every time that we eat. We have to remember that when someone has diabetes, the system is broken. They require medication or insulin to handle the basal amount of insulin and also the bolus of food that they're eating. So when we're using a sliding scale, this is not what we're doing. We're waiting for hyperglycemia before we act. So if we follow this example, the patient's admitted to hospital. If we have a sliding scale, we would just, if the patient is eating and the sugar is 6, we would say, oh, the sugar is normal. According to my scale, I don't need to give any insulin. The patient eats, so what happens? The patient's received a bolus of carbohydrates, but we have not given the patient any insulin. What will happen? Lunchtime, the sugar is high, and we say, oh my God, the sugar is high, let's do something about it. So now we go to our scale, and in this example, we need to give the patient 4 units of insulin. So we give the patient 4 units of insulin. By dinner time, the sugar is back to normal. So now we're happy. We say, oh, the sugar is normal. We don't need to give the patient anything. The patient eats, has a bolus of carbohydrates that we're not handling with insulin. Then what happens? You can guess. The sugar will go up. Now at bedtime, we're having to do something about the high blood sugar. And we're giving the patient, if we follow this, a bolus of insulin at a time when physiologically we don't need a bolus of insulin. So what's likely to happen? Then we're putting the patient at risk of hypoglycemia. So this is where we have all these ups and downs in the blood sugar, and we're really allowing hyperglycemia to occur and not having a stable blood sugar. So we're putting the patients on a roller coaster, and we need to go to this basal bolus correction insulin, which will help patients get off the roller coaster and have a much smoother blood sugar control. So other reasons, other evidence to support this approach, there was a couple of studies done by Dr. Ampieres in the US where they compared with randomized control studies comparing basal bolus insulin, that's what the RABIT stands for. RABIT is randomized basal bolus insulin therapy for type 2 diabetes. This was the population that they studied this on. And what they did is they compared using basal bolus insulin to sliding scale insulin. And what you can see here is that patients who were on basal bolus insulin were in the target range much more quickly within a couple of days, and they were stable there for the duration of up to 10 days on average. And patients who were on sliding scale has much higher sugars, and it took much longer to get them to the target range. They repeated the study in the surgical population, and we see the same thing where we much more quickly bring patients to the target range and maintain them there much more quickly than with sliding scale insulin. The other thing that they found on the surgery study is that patients who were on the sliding scale insulin had almost 4 times the rate of surgical site and wound infections compared to people who were on sliding scale only. And this was statistically significant. We saw a trend to more complications in patients with sliding scale compared to bolus, but the other place where this was statistically significant was with all kinds of complications, the various inpatient complications, as well as the length of stay in the ICU. All of these were statistically significant. So again, support for using this basal bolus insulin therapy. So what tools do we have at our disposal to do this in the inpatient setting? We have the right types of insulins with the newer insulins, insulin analogs. We have insulins that are long-acting and that have no peak, which are good for basal insulin. And then we have rapid-acting insulin that nicely mimics the physiological insulin bolus that we would have if we had a working pancreas. So there are different types of insulin in the long-acting range, and this will depend on your hospital, which ones they carry. The most popular ones are Lantus and Levemir, and these take about 90 minutes to get into the bloodstream. They have no peak, and they last up to 24 hours. And they can be given most of the time once a day, but can be given twice a day if necessary. We can still use NPH, but NPH does have a peak and does put the patient at risk of hypoglycemia and is used less frequently, but in some situations it's useful. It does only last up to 18 hours and always has to be given twice a day. For mealtime insulin, the bolus insulin, we have a choice of rapid-acting insulins. But the important thing to remember is their timing with the meal, because they do start to work within 10 to 15 minutes. You need to make sure they're giving as close to the meal as possible. They peak about 1 to 2 hours after the meal, which is about when sugars hits the bloodstream after we've digested our food. And that's why giving it close to the meal, the idea is to have both the insulin and the bolus of food in the bloodstream at the same time so that we have sugar in the target range. After 4 to 5 hours, the insulin is out of the system, again, because it's much shorter acting than the traditional regular insulin, and we have less hypoglycemia between meals. So we have good tools now to do this type of basal bolus insulin compared to what we could do in the past. The other thing that's really important and challenging for nurses in the hospital setting is the timing of the administration of insulin to coincide with the meal and the blood sugar testing. Although this is challenging, it's important to make it a priority and to try not to check the sugar too far in advance. We should really make sure that the patient's blood sugar has been checked within 30 minutes of administering the insulin and of the meal, because if we take it too far in advance, then we may be giving a dose of insulin that's not reflective of the patient's blood sugar status at that time. Now, if we go back to our basal bolus correction regime, this is the way that this would work, is that we would give the patient a basal amount of insulin. If the patient is eating, then we give them a mealtime dose. And then if the sugar is above target, then we correct the blood sugar with a correction dose. We top them up to get them down to their normal range. And we do this at every meal. And we take care to avoid giving a rapid-acting insulin at bedtime, preventing hypoglycemia overnight. That's our basal bolus correction. So if we look at similar example that we had before, when we're using it, the basal bolus correction insulin will have smoother blood sugar, because what will happen then if the patient is eating, even though the blood sugar is in the normal range, we would now give the patient a mealtime dose. In this example, we're giving the patient 6 units of insulin. If the sugar is in the normal range, then no correction is required. Then the patient gets 6 units of insulin. If we're lucky, the blood sugar is in target range. At lunchtime, the patient's going to eat again. So we're going to give them their mealtime insulin, because they're going to consume a bolus of carbohydrates. And then perhaps something's happened, the patient is under stress, they've received bad news, or we've given them corticosteroids, the sugar is high now, so what we're going to do is we're going to give them mealtime dose of 6 units. Then we're going to come over to our correction scale and say, the patient needs an extra 2 units now to correct this hyperglycemia. And then by bedtime, we have sugar in the target range, and then avoiding having that hyperglycemia and the reflex to try to treat with a bolus at bedtime, which puts the patient at risk of hypoglycemia. And then at bedtime, we would give the patient their basal insulin that meets their requirements for, the energy needs that their cells need over the course of the night and between meals when they're not eating. So this provides a much smoother blood sugar level, but it allows for correcting when the sugar is high because of something unexpected or whatever illness or condition may be causing hyperglycemia. So things to remember when we're treating patients with insulin is that we may have to hold their bolus insulin or reduce it if they're not eating normally or not receiving their feeds. We can add the correction to the basal if their sugar is high for any reason. And we really should avoid holding insulin because if we hold the insulin, then we're putting the patient at risk of hyperglycemia. If the patient has a normal blood sugar, that means that the dose of insulin that we're giving is correct. We're giving them the proper treatment. If they're hypoglycemic, then we should treat the hypoglycemia, and we should then assess the situation, try to understand why the patient had hypoglycemia. And if we see that this is a pattern, then we should be calling the prescriber, the physician in most situations, to make an adjustment to the dose, but never hold the dose, because what we're doing when we do that is that we're causing fluctuations we get the patient back on this roller coaster. If the patient's NPO, it's the same thing. But what we're doing now is that we're holding the mealtime insulin because the patient's not consuming a meal. So we gave no bolus insulin. Again, the same thing at lunch. The patient's not consuming anything, but if the patient's sugar is high, we hold the mealtime insulin because we're not covering carbohydrates, but we are correcting by using our correction dose. We're giving the couple of units to correct that hyperglycemia. And then again, we're avoiding giving the patient a bolus of that at bedtime, but instead we're giving their basal, because even though they're in PO, they still require energy, and they will pull that energy from their stored glycogen stores in their liver.